So just for a change, and in honor of Dr. Grabowski, we're going to have an acute care surgery topic instead of a trauma talk. So we'll be talking about severe acute pancreatitis today. These are two talks. One is on the surgeon's role in severe acute pancreatitis, and the second one is management of necrotizing pancreatitis. But those talks it's important that we give those talks together. So in terms of the role of the surgeons in acute pancreatitis, we would like to emphasize that we should take the same approach we have for trauma care and translate that approach, organized care, systems-based, to acute surgical illness. And acute pancreatitis is one of those diseases that frequently surgeons will be asked to, acute care surgeons will be asked to respond to. So just to give you an example of how common this problem is, there are about 100,000 or more hospital admissions per year in the United States due to acute pancreatitis. So it's a common disease. And approximately 2,000 of those hospital admissions, those patients will die because of severe pancreatitis. There are a number of different causes of severe pancreatitis. Gallstone is the most common, 45%. Alcohol, about 35%. Idiopathic, 10%, and other causes, 10%. And could be drugs, postoperative pancreatitis, including ERCP. Trauma is post-traumatic pancreatitis, hyperlipidemia, hypercalcemia, infectious agents, mumps, or other causes. So there is a classification for everything in medicine, right? So there is one for acute pancreatitis. The easiest one to memorize is mild or severe. So 80% of the cases of acute pancreatitis are mild, and 20% are severe. And we'll focus on those 20% today. But I'll give you some information about mild pancreatitis. So the definition and the differentiation between mild and severe is based on the degree of organ dysfunction that the primary disease causes. So in mild pancreatitis, there is minimal organ dysfunction. So the disease is usually self-limited to the pancreas, lasts about 3 to 5 days, and most patients with a mild form of acute pancreatitis will heal and will survive. In most patients, all you need to do is supportive care, which means IV fluids, rest the pancreas, so patients are made NPO, you control pain. Some patients will require a nasogastric tube if they have severe intractable vomiting or ileus, abdominal distension. And most patients will resume their diet once the pain has resolved, and usually after 24 hours. In severe pancreatitis, there is associated organ failure or organ dysfunction and local complications of that disease process. In local complications, we are talking about pancreatic necrosis, we are talking about maybe pancreatic abscess, or we are talking about a pancreatic pseudocyst. So these are the complicated forms of the disease. So the combination of organ dysfunction or organ failure and local complications of the disease process makes the pancreatitis severe. And in terms of organ failure, the most common is pulmonary insufficiency. So it's not uncommon to admit some of these patients to the ICU because they look very sick, they go through a significant systemic inflammatory response, and they have a PaO2 less than 60. But could be GI bleed, could be renal failure, could be hypotension and shock. So there are a number of organ dysfunctions that may occur. And in terms of the systemic complications or systemic consequences of acute pancreatitis, you may see patients that have DIC with platelet count less than 100,000, or severe metabolic disturbances, particularly hypocalcemia or a serum calcium level less than 7.5. So there are a number of early predictors of severity, and surgeons have invested a lot of time trying to figure out what are the clinical and laboratorial parameters that we should look at upon admission and perhaps a day or two after admission to get an idea whether or not the patient will have a turn to the better or to the worse. So there are basically three types of predictors that have been used widely in the last couple decades. One is Ranson's criteria. Some folks have used Apache 2 scores, and some individuals, particularly in Europe, have used SOFA score. So this is Ranson's criteria. This is something that you do at admission, and then you do during the initial 48 hours after admission. So at admission, you look at age. So age greater than 55 years is you get some points. White blood cell count greater than 16,000. Glucose greater than 200, LDH greater than 350, AST greater than 250, or if you're third spacing a significant amount. So people estimate greater than 6 liters, and you can use different ways to figure that out. During the initial 48 hours, if the hematocrit falls by more than 10 milligrams per deciliter, BUN increases by 5, calcium drops below 8, PaO2 drops below 60, or if there is a significant base deficit greater than 4 or 5. So that's Ranson's criteria. In terms of severity of organ failure, people have used the Marshall score, which is one of the grading systems for organ failure. So you give points from 0 to 4, depending on the severity of the organ dysfunction. So respiratory, PaO2-FiO2 ratio, serum creatinine, evaluating renal function, and cardiovascular by looking at blood pressure, systolic blood pressure. So the sicker you are, the more points you're going to get. And another score is the SOFA score, which again is more commonly used in Europe. So you look at PaO2-FiO2 ratio, you look at creatinine, you look at hypotension, but the difference between SOFA and Marshall score is that here you add hepatic insufficiency, so you look at bilirubin levels, you look at platelet count, and you look at the Glasgow Coma score as a measure of central nervous system function. So these are all scores that you can use to estimate the severity of a disease process. This is not specific to acute pancreatitis, but quite frankly, these scores are nice when you use them to analyze a population of patients rather than to look at one specific patient. And basically what they tell you when you go to the bedside and you look at all those numbers and you look at the patient, that patient that seems to be very sick is in fact very sick, but it doesn't give you more than that. So tells you about organ dysfunction, etc. But when you look at that patient clinically, you know that patient is sick. Patient's on the ventilator, patient is distended, patient's unconscious, patient is hypotensive. So all those things together, you can give it a number. But that number doesn't tell you much that the physical exam and your clinical assessment gives you. In terms of management of severe acute pancreatitis, the bad news is that there is no specific treatment for the disease process. Perhaps the future in terms of management of severe pancreatitis is modulation of inflammation. So things that we do in our lab and in other labs in the country trying to minimize the systemic consequences of acute inflammation that's initiated immediately after the disease process starts. But for the most part, we as physicians, as surgeons, what we do is supportive therapy. And the concept of supportive therapy is very important. We need to understand that this we need to have a multidisciplinary approach to treat this disease process. So we use antibiotics, nutrition. Some patients may need endoscopic interventions. Some patients will require a period in the intensive care unit, and some patients will require the care of a surgeon because they will be treated by a surgical intervention. So you may need to use a number of healthcare providers to take care of those patients. What's the importance of infection in acute pancreatitis? And this is a theme that causes always a lot of anxiety when you're treating these patients, and a lot of confusion in terms of the management of patients with acute pancreatitis and infection. 50% of all deaths that occur in patients with acute pancreatitis are due to infection. So infection is a big problem. Now, infected pancreatic necrosis carries a mortality of 40%. So if you have severe pancreatitis, defined by those criteria that I just described to you, and you have infected pancreatic necrosis, mortality will be 40%. Now, surgical management of infected pancreatic necrosis carries a mortality rate that varies between 20 and 50%. So no matter how you look at this problem, when infection is present, you know that that patient, the likelihood of that patient dying approaches 50%. So infection is important. And just to give you an idea of the incidence of infection as it relates to the days after the onset of the symptoms, most patients that will succumb from infection will develop signs of infection between the 2nd and the 3rd week after the onset of the symptoms. But it could be as early as a week. So as you can see, 71% in this particular study of patients that develop pancreatic infection had a well-defined, clearly diagnosed infection between days 15 and days 21. So how about infected necrosis and organ failure? So what this chart tells you is that if you just have sterile necrosis, so you have a severe form of the disease process with necrosis, peripancreatic necrosis or pancreatic necrosis, but no infection, pulmonary sepsis and coagulopathy will be, the incidence will be much less when you compare to patients that have severe forms of the disease with an infected necrosis. So what this tells you is that infection on top of necrotic tissue will cause more organ failure and more systemic consequences. So statistically significant for pulmonary sepsis and coagulopathy. Now, how do you make the diagnosis of infection is another issue that has created some confusion as well over time. You can make the diagnosis of infection by looking at clinical parameters, but we know that those are not very sensitive. The new kid on the block, if you will, is using procalcitonin as a laboratorial or a lab test to suspect of infection. I'll show you some data. Traditionally, we've used C-reactive protein as another measure. CT scan, you may find some indication of peripancreatic infection or infected necrosis looking at the CT scan. I'll show you some images. But the gold standard is really sampling the necrotic tissue, sending it for culture, and having a positive result. So fine needle aspiration is still the gold standard for the diagnosis of infection. So what are the clinical parameters that will help you think about infected necrosis? High-risk patients, so patients that have extensive necrosis on CT carry a higher chance of developing infection than patients that have small areas of necrosis, and that's intuitive. Timing, so if you suspect that something is not going right and you're between the 2nd and 3rd week, so that suggests infection because we know that most patients that will develop infection will do so during that time frame. Lack of improvement or patients that are not getting better, they're getting worse, suggests infection. So if you have a patient that's been in the ICU for 10, 12 days and things seems to be stable, not getting a lot better, but not getting worse, and then suddenly the patient develops a new organ failure or a new organ dysfunction, or the patient develops worsening of their organ dysfunctions and becoming organ failures, you need to think that they are developing some degree of infection. This is the study that was published in the Annals of Surgery in 2007. One of the several studies that looks at procalcitonin as a method for early assessment of pancreatic infection and overall prognosis in severe acute pancreatitis. And what this guys did is they did a multi-center study, 5 centers, enrolled 104 patients, and they measure procalcitonin 3 to 4 days after the onset of acute pancreatitis. And they defined that abnormal values when the levels are greater than 3.5 nanograms per ml in 2 consecutive days, and the sensitivity for pancreatic infection with organ dysfunction or failure was 93%, and specificity was 88%. So pretty decent sensitivity and specificity. And this is what the data shows in detail. So you have sensitivity, specificity, positive predictive value, and negative predictive value. If you have infected necrosis, sensitivity is 65% compared to 41% when you use C-reactive protein. Now, if you have infected necrosis plus multiple organ dysfunction syndrome, and you use a cutoff of 5.6 for procalcitonin and 430 for CRP, you see the sensitivity is 90% in favor of procalcitonin compared to 50% for CRP. And if you look at death, so using this as a predictor, procalcitonin has a 100% sensitivity when you use a cutoff of 3.5 or above compared to 63% with C-reactive protein. And if you put all together infected necrosis, so if you add variables to your model, infected necrosis, multiple organ failure, or death, procalcitonin performs a lot better than C-reactive protein. So this is probably something that we should be paying more attention to and be using more often since the data is pretty convincing that it performs better than the traditional C-reactive protein. I told you that there are some indication on CT that may suggest infected pancreatic necrosis, and the most characteristic radiographic sign on CT is presence of gas bubbles. And you're going to see that if you, in 30 to 50% of patients that have infected pancreatic necrosis, you may see something like this. So a lot of inflammation, a lot of areas of the pancreas that are not being perfused, and some gas bubbles in those areas. Fine needle aspiration, I told you, is the gold standard, has been the gold standard since the mid-80s. It can be done, it can be TC or ultrasound guided. You send the specimen for Gram in cultures. The problem with fine needle aspiration is the false negative rate that varies between 20 and 50%. So when you get a positive result, it helps you. But if you have a patient that's deteriorating in the ICU, you say, okay, this guy probably has infection. You stick a needle, you get a sample, and you don't get a positive result. That could be a false negative result, and that happens between 20 and 50% of the time, but yet the patient has infection. And that may complicate the treatment and may delay intervention for the infection. So there is an issue with FNA, although it has been the gold standard. Now, what are the recent advances in management in severe acute pancreatitis? Obviously, now we understand the disease process better. We understand the systemic consequences of the disease, so critical care management has improved. Also, in the early 80s, most of these patients were being treated with total parenteral nutrition, and now we know that if you feed them distal to the duodenum, they do much better. So enteral nutrition has been an advance. Obviously, now we have more data on antibiotics, when they should be used and what type. There are new diagnostic and therapeutic modalities to treat complicated acute pancreatitis. And perhaps the most important advance in management has been the understanding on the part of surgeons that you should delay the operative intervention as much as you can. And we will be talking a lot about it in the next talk. But delayed operative intervention actually improves survival compared to early operative intervention. So let's talk a little bit about surgical management. And this is specifically analyzing early versus late necrosectomy, so the removal of all that peripancreatic necrosis in patients with severe necrotizing pancreatitis. This is one of many studies that are out there, and I picked this one because this is almost 12 years old, which tells you how this concept evolved over the last decade. So in this particular study published in the American Journal of Surgery, they looked at 36 patients with severe acute pancreatitis, and they divided patients into two groups. Group A, 25 patients, they underwent necrosectomy between 48 and 72 hours of the diagnosis, and the mortality of that group was 58%. In 11 patients in Group B, they did necrosectomy after 12 days of the diagnosis, so they waited long enough. They tried to maintain organ function, good critical care, volume, antibiotics, nutrition, and they waited as much as they could. Mortality in that group was 27%. There was actually, because of the sample size, no statistical significance, but there was a significant mortality odds ratio in favor of Group B compared to Group A. So the study was actually interrupted due to high mortality rate in Group A. Now, why is this concept important? So if you haven't done one of these operations, you need to understand this is one of the most difficult operations you're going to do. And waiting long enough so there is a surgical plane that you can create between the pancreas, the area of necrosis, and the adjacent organs. Waiting long enough will allow you to do an operation that will bleed less. You're going to remove less viable tissue. If you do it early on, you're going to remove a lot of tissue that may recover. And obviously, the end result is that you're going to have a patient with less endocrine or exocrine pancreatic insufficiency because you're removing less viable pancreatic tissue. So you need to be patient and you need to wait. This is a more recent study published in 2005, so just to give you that idea of the evolution of the concept. So they had 88 patients with severe acute necrotizing pancreatitis. They started out putting them in the ICU, conservative ICU treatment. 60 never developed infection, 28 developed infection, and infection was diagnosed by FNA. And between around 19 days after admission. So they focus on that group with infected necrosis. So they continued the ICU treatment and didn't operate on those patients. And they proved in this study that if you're a patient, you wait long enough, and the organ dysfunction and organ failure, or in other words, the patient is not deteriorating, you can treat a subgroup of patients with infected pancreatic necrosis without surgery. So this is an evolution of the concept of late intervention. So 20 years ago, we were operating early, and we probably had a lot of deaths. 10 years ago, we learned that we should wait, and we had less deaths. And now, 4 years ago, this group published this paper that shows that you may not need to operate on everybody with infected pancreatic necrosis. So they did elective surgical intervention because they waited long enough in 12, and they treated a group of 16 patients without operation. 6 had no complications, 10 had some degree of organ failure. Of the 16, only 2 died. So this is remarkable because perhaps defines another option of management when you have a patient with necrotic infected pancreatitis. which is non-surgical treatment. I'm not advocating non-surgical treatment, but I'm telling you that there might be possible to treat some of those patients non-operatively. And this is the real final result of that study. Mortality was 12.5% if you didn't operate on infected necrosis, compared to 20% if you waited long enough to operate on infected necrosis. Obviously, it would be 50% if you had done early intervention. So as you can see, this concept is a concept in evolution, still evolving. So after that paper was published, obviously people will start paying more attention to this. And this paper actually questions the role for conservative management of infected pancreatic necrosis. So should we just watch everybody and try not to operate? This paper concluded that conservative management is effective in patients with infected pancreatic necrosis. So a little more evidence. In this one, published in 2007, says that non-surgical treatment is very effective and safe in acute necrotizing pancreatitis, and avoiding or delaying surgery in this disease may have a favorable, favorable frontier in clinical practice. Now, this study in 2007 looked at 224 patients in Korea. 77 had sterile necrosis diagnosed by CT. 31 had infected pancreatic necrosis, and infection was confirmed by cultures and gas on CT. Treatment strategy initially was IV fluids, analgesia. TPN was used until they could tolerate a PO diet. They used prophylactic antibiotics within 48 hours of admission when they had patients with greater than 30% necrosis, and they changed the antibiotics based on cultures. So, you know, basically what we do in the ICU. They looked at percutaneous drainage of infected necrosis compared to other modalities. So percutaneous drainage with a 20 French tube, irrigation with 3 to 4 liters twice a week, if the patient had extensive necrosis or no improvement with antibiotics. So this is something different than what we were talking about. Or endoscopic drainage of retrogastric fluid collections, or operative intervention when there was no improvement with clinical management. So here they are adding 2 other modalities of management in a disease that until 10 years ago was purely treated by open operations. And basically what they found is that 8 patients were treated with antibiotics only, and they improved. 31 patients, of the 31 patients with infected pancreatic necrosis, 19 received antibiotics prophylactically, 5 underwent endoscopic drainage, and 18 underwent percutaneous drainage. Of those 23 patients, only 4 required an operation. So again, you don't need to operate on everybody, and if they need an intervention, maybe a surgical intervention is not the most appropriate, and perhaps in selected groups of patients, endoscopic drainage and percutaneous drainage may be effective. And so there is some indication that other interventions, in addition to a formal exploration, may be as effective, or may be an adjunct to the complex management of these patients. And if you look at 31 patients with infected pancreatic necrosis, only 1 patient died using this stepwise approach. So I think that the message, at least the way I interpret this data, is that ultimately a specific number of patients will require operative intervention, but you don't need to operate on everybody with infected necrosis. You may be more conservative, and the results may be as good or better. In summary, that paper shows clinical improvement without operative intervention in 26 patients, or 84%. In those that required necrosectomy, so 4 patients required an operative intervention, 13%. 1 died before the operation. 4 patients that they operated on, 3 of the 4 underwent percutaneous drainage prior to operation. Mortality was 1. So 3.2% mortality is pretty remarkable. So what they say in the manuscript is that intensive medical management is very effective and safe and can delay or eliminate the necessity for surgery. So here we are in 2009, learning that not everybody needs an operation and we can use percutaneous drainage or other more conservative modalities. So this is what I concluded from reading this literature. Pancreatic infection in severe acute pancreatitis. If you have infection and no organ failure, you attempt conservative or medical management. If you have infection and organ failure, you should postpone your operative intervention if possible, at least for 2 weeks. And at that point, if the patient is stable, you keep watching. If the patient deteriorates, then you need to think about a formal operation versus a less invasive procedure. How about pseudocysts? So pseudocysts are common. We see this all the time. We know that most of them, or at least half of them, will resolve spontaneously, and you treat only if they are symptomatic. There are a number of ways to treat pancreatic pseudocysts. Doing this operation open is a lot of fun. Those that like to do it laparoscopic think it's a lot of fun as well. The reality is that obviously the endoscopists love to drain pseudocysts by endoscopic means, so you avoid an operation. So there are a number of possibilities. In terms of surgical drainage techniques, cyst gastrostomy for pseudocysts, they're impacted against the gastric wall is the operation of choice. Some may require Roux-en-Y jejunostomy, and distal pancreatectomy should only be used for pseudocysts that are located in the tail of the pancreas. Now, just to wrap this up, I said that the discussion would be in terms of the surgeon's role. I don't think we should give this up because we're being more conservative. I think this is a surgical disease, and the surgeon's role in acute pancreatitis is the same role that the surgeon plays in trauma patients. The surgeon is the team captain. You need a multidisciplinary approach to treat this disease process, but ultimately the decision is ours. When is it time to take the patient to the operating room, or more important, does the patient need an operation? And that's a surgical decision. It's not anybody else's decision. So I think we have the same role as a trauma surgeon. There are too many details and complex decision processes going on. We do the critical care management anyway, and this patient should be in the surgical ICU, not in any other ICU. And decision about diagnostic modalities and timing of the operative intervention, again, is part of the acute care surgeon's job. Any questions?
If I actually just have a quick question based on, I think this is actually mostly going to be for your second talk, but perhaps I can preface it. Since we're now, based on the data, we're going to delay operative intervention. But there still is a need for operative intervention occasionally. If there's only about a 50% negative predictive value, or even a positive predictive value of a needle core biopsy or an FNA, then what's going to lend or help your decision-making to actually operate?
So it's the worsening or the worsening of organ dysfunction or the development of a new organ dysfunction. So it's the clinical course that will dictate those that will require a more aggressive approach versus those that will require a more conservative approach. So I think it's the clinical picture that will dictate which way you're going to go. So if you have 50% false negative rate in FNAs, but the patient is getting worse, the patient is probably infected. So at that point in time, you need to decide, is the patient infected but stable, or the patient is worsening? If the patient is getting worse, then the decision is, should I do percutaneous drainage? Should I do a endoscopic procedure? Should I do an open operation? I think that's the decision tree that you need to follow. But again, is the clinical picture, the stability of the patient in the ICU and the development of new organ dysfunction that will guide your management.
And what are your thoughts on percutaneous drainage alone?
So we'll go through this in this talk.